This podcast is intended to provide information for educational purposes only and to serve as a starting point for you to have a conversation with your personal physician. Nothing stated on this podcast should be considered medical advice. Consult with your physician before undertaking or changing any treatment plan.
Welcome back to the Pound of Cure Weight Loss podcast. How are you doing, Dr. Weiner?
I'm doing great. How are you doing, Zoe?
I'm doing great too. Body's feeling good after kind of a lot of injuries that I've been recovering from. So I'm finally feeling kind of good.
I'll tell you, it's interesting. I get together with some really good friends once a year, and we kind of have a lot of athletic competitions in this. And it used to be whoever was in the best shape would kind of win the event. Now it's whoever's the least injured. And I'm quite a bit older than you, so I think you're starting to get a little bit of a taste of what us people in our folks us folks in our 50s kind of struggle with. But I've been saying this for over a decade that the secret to exercise is not getting hurt.
Mm-hmm.
As long as you can avoid injury, that really is the secret.
Yeah, and it's so funny because I used to, just jump right into the workout or go running or whatever. And now it's like I need to spend 15 minutes warming up, do my dynamic stretching, and really like make sure that we're safe going forward. So yeah, I'm excited. My half marathon is next Saturday. So
oh my gosh,
we're getting there.
I've run 3 marathons. 3?
Really? I didn't know that.
Yes, back in medical school. I went for a very brief moment in time where I was super into running, and I ran 3 marathons, and I think running a mile right now would be very hard on my body. So
you're like, been there, fleeting. Done that. I'm done.
I did it, got the medal, moved on. So I had the most delicious thing. My wife and I made it, and it was so easy and fast. I got to tell you about it. We ate it. We're like, oh my God, we got to talk to Zoe about this. So we went to Trader Joe's. The whole thing was like $20 for our grocery list, right? So we got chicken breast, and just, we splurged and got the pre-cut broccoli. Just one less thing to do.
Getting fancy out here.
Love it. And so with a little bit of olive oil, we sauteed the chicken breast and kind of sauteed the broccoli. We cooked them all together. And then we added soy sauce, salt, a little bit of nutritional yeast. Have you ever used nutritional yeast? Yep. Just a little bit. It's like Parmesan, basically.
Yeah.
And then here's the magic ingredient: peanut butter.
Oh, you made
so it was like a peanut butter Thai chicken broccoli. It literally took 20 minutes to make. 100% Pound of Cure approved, and it was freaking delicious.
Oh, I love that. I will have to try that. That sounds really good.
Give that a shot. Yes.
Love that.
All right. So what are we going to talk about today? We got some big news articles.
Yeah, we've got some articles to talk about, and we've got some questions. So I think it's going to be a good show, a little bit of everything. So you want to kind of get us started on our big news?
The big news is that Trump RX is going to now offer obesity medications. And the details are a little flimsy. Like, some of them basically said they're going to offer Wegovy and Zepbound at like $350 per month starting, which is what you can get on Lilly Direct right now. So they're essentially, the details are not, there's not a lot of details, and I don't think a lot has been agreed on. But in essence, here's what I'm seeing from this. Traditionally, Medicare, Medicaid would go through pharmacy benefit managers to purchase these drugs. And it looks like some of those barriers are being broken down. And so it's allowing, and essentially what we're seeing is the government negotiating directly with pharma, which has been something that has essentially been forbidden. Which is one of the main reasons why our drugs are so much more expensive. Every other country uses their buying power to negotiate with pharma companies, and we haven't done that, and we're starting to. But in all honesty, it's gotten to the point where it's crazy.
Mhm.
And nobody likes the fact that they're selling drugs for $1,100 that they make for $5. And these are medications that we need for our health. That's just, that's crazy. It's like if all of a sudden you drove out onto your main road and they're like, that's going to be $20 to drive down the street today. You'd be like, well, that's crazy. I need to drive down the street because I need to go to work, but you'd be pretty pissed off about it. And that's essentially what's happening with medications. I need these medications. My doctor said I should get them, but I'm being charged in a ridiculous amount. So all of a sudden, what we're seeing, and this is also in the midst of this government shutdown, which is primarily about healthcare, we're
Mhm.
seeing a huge amount of political attention being directed at healthcare. And I think this is just the very beginning. My personal opinion, and you heard it here first, is that our financial payment system for healthcare, Cigna, United, Blue Cross, Aetna, Medicare Advantage plans, will not make it through the rest of this decade. We're
Mhm.
going into 2026. And I think that we won't, by 2030, we will not have a functioning financial payment system. That your typical insurance, and in my mind, this is probably a good thing because how much worse could it ever be? And perhaps it would actually put financial pressures on hospitals, pharma companies, doctors' offices, nursing facilities, all of the healthcare facilities out there to provide higher quality at a lower cost.
Mhm.
Right now, there's zero pressure to do that in our payment system. None. In fact, I always talk about this. If I doubled my complication rate, I'd make more money.
That's so
Isn't
crazy.
that crazy? Because
I was
those
going to use a different
complicated,
word, but
yeah, the take backs and complications, you get paid a ton for those. You do a perfect surgery and have somebody out the door, you don't get paid anything. And so the financial pressures actually support poor, low quality care. And that shouldn't be any surprise because anybody who's been using the doctor lately, that's what you're generally getting. When it is not user friendly, it is not a good experience for patients, and that's we got what we created. A lot of corporate profits, very little high quality, low cost care. So
Mhm.
I think the details of this whole thing they're flimsy. We don't know what's going to happen with this whole Trump RX thing, but we do know that all of a sudden we're looking directly at costs. What was also really interesting is they're looking at Medicare and even Medicaid being able to purchase through this program, which is going to extend access to these meds. And
Mm.
that's really cool. They're going to have to pass a law though, because it is a federal law that Medicare can't cover obesity treatment, obesity medications. They made that after fen-phen, and so you're gonna need a law to be passed, which is going to require a majority vote, which is seems quite difficult these days in the political
Doesn't seem to
system.
have a good track record.
Yeah. So I think you might look at this and be like, problem solved, problems not solved, but it is a move in the right direction. I'm glad that we're doing this. I'm glad we're paying attention. Anytime you're talking about price in medicine, I think that's a good conversation to have
Mm.
because it's
Mhm.
out of control. It's hidden. There's no transparency. That's something we're really working toward in our practice is we want to make sure every single patient who sees us knows exactly what they're going to have to pay to meet with us. That's our platinum program is that, hey, we created a good program. This is what it costs. We're going to give you good care. We're going to help you lose weight. We're going to help you save money on the meds. And this is our price. And we're working
And
on
don't
that with
even deal
surgery
with
too.
the
Yeah. Patients are like, how much is this going to cost me? And I feel terrible. I'm like, I have no freaking idea. And I have no way of finding out. We're
Mhm.
sorting through that and we're actually coming up with some ways where we can do that. I think that's just so important. If you don't even talk about the price, well, how are you going to lower it? The first step is at least saying, here's the price.
Right.
So we're talking about price in medicine, which is great. Any conversation around that, I'm in support of.
Hmm. Be very interesting to see what happens. Like you said, we're coming into 2026. I've been feeling like for a while, and we've talked about this on the podcast before, that it feels like something's coming to a head, and there has to be some change that
Yeah.
happens. So I'll be interested to see what happens over the next couple of years, with going along with what you
I-
said.
we're a small business, our practice, right? And so we buy health insurance for our employees, and it went up 25% this year. And so, I look at this. I gave my employees a raise because we didn't pass that on to them, and so we gave them a raise, and so, like, that's, that my employees don't look at it that way, and I understand why. But that's, we when I see this 25% in 1 year,
Wow.
I think we've passed the tipping point,
Hmm.
you know? And
Yeah.
I think we have gone, and there's a couple of things that are happening. I'm seeing them happen, in terms of how, and what you're seeing is doctors are leaving networks. So not like you're paying, between you and your employer, you're paying $1,000, $1,200 for a family, and no doctors accept that insurance.
Yeah.
And so that just tells you, where's that money going? Clearly not to the people who you want them to go. You want your doctor to see you.
Yeah.
So I think we've hit the tipping point. I think, like I said, by the end of the decade, it's gonna, it's gonna come to a head.
Hmm. Well, so I guess we'll stay tuned.
Yeah, for sure.
All right, so our next article actually is showing that there is change in the data around obesity. So it comes to
I
us
love
from
this.
Fox. I know, it's so exciting, right? It's
Yeah,
like finally we're starting to see those scales tip a little bit. The title of the article is "The Ozempic Effect is Finally Showing Up in Obesity Data." And this article basically shows us that from 2022, obesity, this was self-reported obesity rate of 39.9%. So basically 40% in 2022, down to 37% in this year, 2025.
yeah.
So that is a meaningful decline, the first one in years.
Uh, First one ever,
Yeah.
I
Because
think,
it's always
since we've
been
been
going
recording
up.
it. Yeah.
Yeah.
Um,
Yeah.
I mean, we're getting thinner.
Hmm.
Our country is
And
getting thinner.
that's what also it was saying, is that, back in 2024, 6% of Americans were using this medication. And now, only 1 year later, it doubled to 12%
Yeah,
of US
yeah.
adults.
And the cost comes down, it's going to double again.
Mm-hmm.
Um,
Mm-hmm.
and we've been talking about this for a while now. Obesity is 100% treatable, right? Patients come in, they're 500 pounds, and I'm like, we're going to get this fixed. You can live your life at half that weight. And so, it really is the interplay of meds and surgery, and it's the two together that allow me to say that, because 15% of people don't respond to the meds. And I think that's really, we see this all the time in our
Mm-hmm.
practice, and it's kind of devastating. That's a problem I don't think we've solved yet. It's going to be interesting as we see new meds come out, and we do see some people who respond well to one but not the other, but it's not a lot. Often, if you don't respond to Wegovy, you also don't respond to Zepbound. That's not 100% true, but we certainly see that. Uh, if there's five drugs, does that, increase your chances of responding by five times or not? That's an answer we don't know. Um, and so this to me, though, is great because we we've been gaining weight for 40 years, 50 years,
Mm-hmm.
and now we're finally not. And this is really something to be celebrated.
Yeah. Something that I'm interested to see what will have a ripple down effect on is childhood obesity. If if obesity among US adults is going down, and maybe that's changing the household environment, and maybe that is changing some food environments or eating patterns, or how families interact with their relationship with movement and physical activity. I just wonder if we're going to see a ripple down to childhood obesity without necessarily having children on the medication.
Yeah, well, here's something, GLP-1s are contraindicated in pregnancy and nursing. Um, what how's that going to play out, right? You know, the big concern is neural tube defects. It's very, very flimsy data.
Mm.
These meds stay in your system for a long time. The current recommendation is stop taking them before you try to become pregnant. But
Usually they
if you
stop taking them because they become pregnant because they've lost the weight.
we've seen that many, many times as fertility increases, and I don't know that
Mm-hmm.
there's that awareness. But I think we're going to be able to study these people who were taking GLP-1s right up to pregnancy, and
Yeah.
what's the rate of childhood obesity there versus it's going to take 5 or 10 years to figure this out, but it's going to be fascinating.
Very fascinating. Going back to the concept of these different DNA, different genes and the DNA get turned on versus turned off in the environment, and if the obesity is changing in the maternal and paternal DNA, how is
Right.
that impacting the fetus? I think that's a really cool
Yeah,
thing
I
to
mean
think about.
the epigenetics of this all, right?
Mm-hmm.
Are the GLP-1s preventing the genes from being turned on in the children, and how's that all going to play together? That's going to be really, really fascinating. What do you think from a dietitian perspective? I mean, because you were practicing before GLP-1s.
Mm-hmm.
How does that change your conversations with patients, the way you counsel people? Like, what's changed in your space? What are the other registered dietitians saying about these meds? Um, you know, Give us the dietitian's perspective on the meds.
I think that at first there was a lot of, because of the unknown, a lot of
Sure.
hesitation, right? And, before working with Pound of Cure, I kind of had that same I didn't know. So I had hesitation around bariatric surgery. Now, of course, being in the space and working with patients and knowing how much of a life changing experience it can be, obviously, the more we learn, the more we grow within that, kind of mindset. I see that a lot with dietitians and maybe, and in even not just registered dietitians, but, this is a little bit flimsier of, online health coaches or fitness influences or whatever. I
Right.
think that space maybe still has some extra stigma around that using GLP-1s, unless it's glamorized as peptides, right? And then
Exactly. And they can make money on it.
and they can make money on it, exactly.
Yeah.
But I think in terms of how this has been a trajectory and a learning experience, not just within the field of dietetics, but with the patients, more we've seen it double in the last year, right? People on these medications, you know, it would be it would be out of touch to just be having like such a rigid
Yeah.
mentality around whether or not they are helpful, or you shouldn't use them, or whatever personal biases other dietitians might have. But just seeing how we can help these patients use the tool, just what we talk about all the time, use
Right.
the tool to change the lifestyle habits and really view it as this amazing opportunity that we didn't have before. Because we talk about phentermine and it's like, kind of scary, and
Yeah.
not something that as dietitians we necessarily would love to see people on. But now with this new class of drug, it's really changing the game, and I think it definitely opens up a conversation for how do we, obviously this is what I do every day, but other
Yeah.
dietitians that I've either mentored or they've asked these questions about how do we help these people on GLP-1s, and it's exciting for me to be able to kind of lead the discussion in those areas of other dietitians to help them help their patients more.
Yeah. I think another thing is just, because just straight up lifestyle changes have such a low success rate that I got to imagine just being a strict lifestyle only dietitian would get very frustrating,
Mm-hmm.
because so many people are just, they lose, and you're like, oh my God, amazing, you're doing so great. And they lose 10% of their body weight by trying with every fiber of strength that they can muster up. And
Mm-hmm.
then, you bump into them 6 months later and they've gained the weight back, and that traditional kind of yo-yo dieting, and really very low success rate for long-term durable weight loss from lifestyle alone. Now, all of a sudden, you get to be part of this this solution that actually does result in long-term sustainable weight loss. And I think that's when you talk to other dietitians who work in the bariatric space, that's something they really love about it is their patients are losing weight. That's what
Hmm.
they wanted to be a part of, and now it's very reliable, and they get to celebrate as opposed to kind of counsel, almost be a grief counselor, right?
Every single
Yeah,
session.
yeah,
And it's frustrating for the patient, it's frustrating for the provider, and it's
yeah,
just like you feel so drained. They feel drained because they've been working their butt off.
right,
As the provider, it's draining to continue trying to, encourage and come up with new ideas when they're doing
yeah.
like everything right, truly. So, yeah, it's a game changer for sure.
Yeah, I think another thing that's really interesting, and I think most of the dietitians have kind of figured this out, is with bariatric surgery, it actually dramatically increased the need for dietitians,
Hmm.
right? And I think GLP-1s have really done that. There is a right and a wrong way to eat on GLP-1s, and there's a lot of people who just, well, I'm just going to portion control it. I think what we're going to find is the same thing we found with bariatric surgery, that portion control trap that we've talked about with bariatric surgery. I think that exists with GLP-1s. And yeah. And so taking a GLP-1 in my mind increases your need for a dietitian. It doesn't decrease your need for a dietitian. It doesn't replace it. It actually makes it, more of a challenge to figure out what you should be eating and what you can do to leverage maximally the effects of these drugs and the sustainability of the weight loss that we see from the
Absolutely.
meds. So,
Yeah, and if
so
you're
th-
spending that much money on these drugs, wouldn't you want to get the most
yeah,
out of it? And that's, definitely where a dietitian can come in handy and really working with like the individual, right? Because
yeah.
everybody's so different.
And I think that's something we're really working toward in 2026 with this app is to kind of take, if you're on GLP-1s, what should you be doing to really get the most out of them? And we're looking to kind of use both AI and human guided, registered dietitian guided support to help patients really maximize the results of these drugs. I think our app is good. It's not great. I think we're going to get it to great next year. And I think that that's a really important thing we have to bring into the GLP-1 space is what's nutrition look like on a GLP-1? There's been tens, hundreds of thousands of nutrition books, including mine, written over the years. And in my mind, anything written before, say, 2024 is probably irrelevant.
Mm,
Um, and so, what does it look like with GLP-1s? What is the GLP-1 diet, right? I, I don't know that that's been defined. It's a wide open space. It's something I think our nutritional program is really well suited for. My program was designed for bariatric surgery. It's hormonal changes, GLP-1s, bariatric surgery, they both work through the same mechanism. And so, we're looking at that type of program. I still stand by that program as being the best diet for GLP-1s.
totally. There's so much overlap in in the metabolism and how your body responds. And,
Yeah.
that's what a lot of people say who maybe had bariatric surgery and then go on a GLP-1 it's like, oh, it reminds me of when I was in my honeymoon period again.
Yeah.
And it's like, we want
Yeah.
to use it in the same way.
I got my sleeve back,
Yeah,
right? All the
absolutely.
time. All right. We got a couple of questions, right? Maybe we'll go through two questions.
Okay, yeah. So we actually do have some questions that we got from Facebook, some from YouTube. So we'll read one from Facebook right now. This person says that they are not wanting to take a GLP-1, but they want to lose another 20 pounds. I had gastric bypass 3 years ago and lost 80 pounds. I've been at this
Right.
weight for at least a year, not feeling the way I thought I would. I thought I would love living in my new body after a while, and very grateful for the procedure. And the health has improved immensely. And they're just looking to lose an extra 20 pounds. Right now, their weight is 173 and 5'3". Really could use some advice.
Yeah. So this person started out, it sounds like around 250, lost 80
Mhm.
pounds down to 173. What I hear is that this is someone transitioning from the honeymoon period to the end of the honeymoon period. Right? Would you agree with that, Zoe?
Yes, and having that expectation management, I think, is
Yeah.
huge too.
So I think the first thing that if this person comes to my office and we're having this conversation, the first thing I'm going to do is pull out our calculator. We have calculators on our website. I think we're going to start putting them out on Instagram too, so that so the people out there can use them. But what we have a calculator that allows you to predict how much weight you're going to lose. This weight loss sounds to me to be kind of right in line with what I would expect. And so, depending on your age and gender and whether you had diabetes and whether you take psych meds, those numbers kind of can be different from person to person. But this to me sounds reasonable. And the first thing I would do is look and say, hey, did you lose what we would have expected? My suspicion is the answer is yes.
Hmm.
And then they want to lose another 20 pounds. I'll let you kind of handle the nutrition part of this. Um, my general thought on this is that, and I used to say, whatever that lowest weight you hit is after your surgery, that's the lowest weight you're ever going to be for the rest
Yeah.
of your life. And I don't say that anymore because of GLP-1s. But I would say that if you don't want to use GLP-1s. And so I think this person is really going through the natural changes that we see after surgery. How are you going to handle this from a nutrition perspective? Because I think that's what this person really is looking for.
Yeah. So I'm gathering that a lot of this body dissatisfaction, let's call it, is not necessarily about maybe what they weigh, but maybe body composition. My question for this person would be, okay, if you were to stay at 173, but maybe you had a little bit more of a toned physique, or you lost some more body fat but we gained some muscle, and really kind of focusing the change on, is there a way that you do feel really great in your body but not necessarily focusing on that scale weight? Then we would definitely talk about, okay, can is there the opportunity of adding in strength training? Can we focus on this body recomposition piece, especially being out of the honeymoon period? We know that in the honeymoon period, that's when there is that rapid weight loss. But coming out of the honeymoon period, that's a really good opportunity, because now you're eating a little bit more to build muscle, right? You're no longer losing weight as fast. So I would definitely kind of explore that further. But if we break it down to just, I want to lose another 20 pounds, obviously we would definitely take an audit of, what are you eating? What are your lifestyle, factors? Is there an area of opportunity for increasing your activity? Maybe we want to do the metabolic reset diet. Was there any weight regain? Are there some of those old habits slipping back in? There's a lot of different directions that we would dig into, but my main thing would be those smaller baby step changes. So, for example, if it's, yes, I work a desk job and I lost a lot of weight because I, was in my honeymoon period and I don't really exercise that much. Could we add in those movement sprinkles during the day, not only to help with increased activity, but, mentally getting a little bit of mental reprieve from that screen, getting some stress reduction? Maybe that will help you sleep better at night, which will overall improve health and ideally help your weight, drop a little bit more too. So kind of finding these little tweaks within your daily routine, or maybe there are some swaps that we can make in what you're eating, or maybe we find that, you were really focusing on hydration in those first couple of years because that's what was hammered into you as part of the honeymoon period, but maybe
Right.
now that has slipped back down a little bit. Maybe you're drinking coffee all morning instead of prioritizing your water. So there are just a lot of these little questions that I would ask, but, having that expectation also of, is this actually where we want to be weight wise based on what's predicted? And then also thinking about it from the perspective of body composition versus weight on the scale.
Yeah. I think, gratitude journaling would probably also be really helpful for this person,
Mhm.
because what I'm hearing, and this is a very human thing. This is why social media is so popular, is because we focus on the things we don't have, not the things we have. And so, you've lost 80 pounds, and they did certainly acknowledge that they were grateful for that. But it sounds to me like most of that energy, most of the thought is going into the 20 they didn't lose, as opposed to the 80 they did lose. And I think reframing that can, that's something that you could control and could, because you may not, without GLP-1s, be able to control whether or not you're going to lose those last 20 pounds. I think if this person is like, okay, great, but I want to lose 20 pounds, the answer is GLP-1s. It's probably low dose GLP-1s. And that's not necessarily such a bad thing. I think we look at GLP-1s as this binary decision, and I would never ramp this person up to the highest dose of Zepbound, like never. But would a touch 2.5 milligrams, the starting dose of Zepbound, plus working with Zoe to really, um, get the lifestyle as dialed in as possible, build muscle, all those things, we might see 20 pounds of weight loss there. And so that's just the decision you might actually be faced with. And recognizing the parameters of that decision and deciding one way or the other, whichever you feel is best for you. I would encourage that this person, even though they're saying, I don't want GLP-1s, nobody does. But do you not want GLP-1s, or do you want to lose 20 more pounds?
Which one is
That's
more important? Yeah.
that's the decision, the realistic decision you have to make. And if whichever way you choose, it's totally your decision, your body, your choice. But you know
Yeah.
that's kind of the way I would look at this.
And I just have to call out the fact that I love you mentioning the reframe and where you're putting your energy and your focus and that gratitude, because we know, and this is actually something that I work with patients on a lot. And even though maybe it's not necessarily nutrition coaching, it's like,
Hmm.
to me, so powerful and such an important part of the journey on that mindset side of things and how you're
Right.
speaking about things and thinking about them. And when you're putting all of your energy and focus into the lack, then that's what you're going to get more of. So good job
Yeah.
calling that out. I love that.
Thank you. All right. What's our last question?
Okay, last question comes to us from YouTube. Hey guys, I'm recently diagnosed celiac. It's so restrictive. I was hoping y'all might have some insight. And it looks like this person got a bypass 3 years ago, lost 89 kilograms. So
A
amazing work
ridiculous, like
there.
200
Huge.
pounds.
That's a
Yeah.
lot. So just wanting for some advice for specifically celiac patients. So I'll kind of get started on this. You
Sure.
know, the metabolic reset diet is great for people who are gluten free, right? If we're thinking about eliminating grains and focusing on whole foods, not necessarily low carbohydrate, but still having those high quality, complex fiber rich carbohydrate sources, as well as all of our other great metabolic reset diet aligned foods, that's a really good place to start. But taking it a step further and being able to individualize this is a beautiful place to start on the app, because you can really, the Pound of Cure app, if you don't have it downloaded, it's free. We have Sage, where you can actually ask, I'm on the metabolic reset diet, but I'm also celiac. Help me with a meal plan. Or you can update your food preferences within the app and say gluten free, so that all of those recipes, all of those meal plans, all of those recommendations that get fed to you will be very individualized and tailored to your nutrition needs.
Yeah. I think also with gluten free, there's kind of variable levels of how gluten free you need to be.
Mm-hmm.
Because I think Tito's is gluten free vodka. Which I guess means that other vodka has gluten in it, which I don't kind of understand. Not that vodka is a good thing for anybody to be consuming on a regular basis, but I think it really makes the point that there's like trace amounts of gluten in everything. And I
Yeah.
certainly know people who are just like so paranoid, like, oh my God, there's the tiniest amount of gluten. And I think this is something you'd have to work with whoever diagnosed you with celiac is there a tolerance for a small amount of gluten? Because avoiding anything with even the microscopic doses of gluten becomes very, very restrictive. But if
Mm-hmm.
we just don't eat bread and things with wheat as a primary ingredient, we can cut that gluten level down to, say, not, from 95%. Is this adequate? And for some people, the answer is yes. And for others, it's no. But that's also something to kind of think through, is that bread and something with trace amounts of gluten will impact someone with celiac disease very differently.
Right, because it's the autoimmune disorder
Mhm.
versus a sensitivity or an intolerance to the
Right,
protein.
right. Where the true biopsied autoimmune disorder is relatively uncommon.
Hmm.
The insensitivity to gluten is extremely common. And so where you lie on that spectrum is something I think every patient who is struggling with eliminating gluten from their diet, they have to figure out exactly where they are on that.
What that kind of upper
Yeah,
threshold is. Yeah, great
exactly.
direction on that for sure. All right, great questions. Good conversation. I like that we were able to address some questions that we got over on the socials and also talk about what's going on in the news and media right now. So, lots of good stuff going on and excited to see what might happen over the next couple years.
For sure. It's going to be interesting. No questions there.
Yeah, absolutely. Well, thank you so much for joining us. We will see you in the next episode and have a good one.
Absolutely. See you next time.